it okay if I start?
Yes,
Yeah,
absolutely. Yeah.
Okay. So welcome to Ground Rounds, everybody. I think that it's not every day that we get a visiting professor from Australia, and I think we have basically COVID to thank for that. It's one of the silver linings of COVID that we're able to gather far and wide and discuss things and learn from each other. So today we have Professor Watson. She's a clinical scientist that's known for her groundbreaking research in corneal therapies. She's appointed at the University of Sydney and Sydney Eye, Sydney Children's and Princess of Wales Hospital. She's had over 213 publications, is invited to speak internationally, and has raised over 10 million for her research program. Data from Stephanie's research has featured widely in Australian and international media, including the New York Times and a Sydney Morning Herald article with a reach of over 8 million, and the film Vitamania. As chair of Ophthalmic Research Institute of Australia, chair-elect to ARVO's Advocacy and Outreach Committee, expert advisor to the 150 million stem cell therapies mission, editor for the Cochrane Eyes and Vision Group, and on the advisory board of Elsevier's Practice Update, Professor Watson contributes to policy and education. She was awarded the NSW Premier's Prize for Leadership in Innovation, the Ransco Council Lecture, First Prize Medical Device Commercialization Training Program, ETP Innovations, or NSW Office of Health, and medical research, and nominated for the NSW Women of the Year and a Pride of Australian Award. She led her team to win the Best Health Innovation Product Idea IDE Group and was awarded the Grand Final Award on the New Inventors ABC television. So Stephanie, thank you so much for joining us. I'm going to turn it over to you, and she's going to be talking to us about keratoconus, what I should tell my patients.
Thank you very much for the invitation and the kind words of introduction. I'll just start sharing my screen. All right, let's pop on the slideshow. Keratoconus. So this lecture is going to feature some advice that we can give our patients about keratoconus. Now, most of you would know that keratoconus is a progressive localized thinning of the cornea. There's a protrusion of the cornea where it's thin, and it's bilateral, but often asymmetric. And the end result is irregular astigmatism. It's been said to affect up to 1 in 500,000 in Russia, 1 in 2,000 in the USA, 1 in 500 in South Korea, and a recent study in Australia looking at Scheinfeld topography on patients in Western Australia actually reported the incidence at 1 in 84, and it's up to 1 in 25 in Iran. Now, this picture here is of the Rapa Common, and the photo is here just to say, look, keratoconus actually is very common. And it's so common that in my very busy clinic today, I actually saw 3 patients with keratoconus. There was Don, a middle-aged man, Peggy in her early 20s, and Sally, who had just turned 16. And all of them came with keratoconus. All of the patients had similar types of questions. They wanted to know, what treatments are there for them? Will their keratoconus get worse? Do they need cross-linking, and if it's safe? How they should have cross-linking, and whether they need any other surgeries? And what will happen to them over their life? And what's the impact of keratoconus on their life? So this was Sally. She had just been told she had keratoconus. She was there with her parents, and she asked, look, what treatment do I need? So look, in newly diagnosed keratoconus, it generally begins with looking at whether spectacles can correct the vision. If it's early and the spectacles give the patient good vision, then this may be all that they need for vision correction. If a spectacle correction works, often a soft toric contact lens could also be used. If you have a patient that has very good vision in one eye, such as 6/6 in one eye and 636, 660 in the other eye, with more advanced keratoconus, then rigid gas permeable contact lenses are often not taken up by the patient. And if they do, they often find it quite a fuss, and it may put them off using it later. It's important to remember that the level of vision that patients need from their correction is not necessarily 20/20. It depends what the patient does. I have some keratoconic patients in my clinic who are quite happy at 6/12 in each eye, unaided, because they can't correct with spectacles, and have tried contact lenses but don't wish to wear them, as they're still able to drive and work. Contact lens fitting, though, doesn't slow the progression. So in cases where there's progression, the next step is corneal crosslinking. And this is where Sally wondered, will my keratoconus get worse? Do I actually need corneal crosslinking? So we went to have a look at the literature to find what evidence there is to figure out who is going to get worse with keratoconus. And for that, we performed a systematic review and meta-analysis that was published in 2019 that included 11,529 eyes. Now, what we did is we included any study with retrospective or prospective keratoconus cohorts where the follow-up was greater than 6 months. We looked at the vision, the refraction, K2, Kmax, K-mean, pachymetry, whether they needed a corneal graft, and whether they'd developed any scarring. Our initial search found 3,923 abstracts, and we were able to include relevant 43 studies in the systematic review and 24 studies in meta-analysis. A lot of the studies reported different outcomes, so it wasn't possible to include them all in the meta-analysis. And this is what we found. So these are scatter plots, and each dot on the scatter plot represents a study. And the size of the dot shows how big or small the study was. So over here is the code. So the larger dots have studies with about 150 patients, and the smaller is 50 or less. And with younger age, there was a greater change in Kmax over the 12-month period. And if the Kmax was higher at baseline, there was a greater chance of an increase in Kmax over 12 months. And the outcome of it was that we found from the evidence that patients less than 17 years old and with a Kmax greater than 55 were more likely to progress. We also found patients in Middle Eastern populations were more likely to progress. Now, we wanted to, when we looked at the evidence base from our natural history review and meta-analysis, many of the studies actually were performed before modern topography. And there were many different ways that the studies were assessing patients with keratoconus, and also many different ways in which patients were using contact lenses before and after they were included in the studies. So we wanted to find out what was happening in the real world with modern topography. And we recognized that registries are an important way to collect data. And using registries in ophthalmology, there's been improvements in quality and research. I established the Safe Sight registry for the cornea. It's based off the Fight Retinal Blindness project, which is currently recruiting patients with ARMD and looking at anti-VEGF injections, and set up a keratoconus registry. Now, the reason for a registry is that unlike clinical trials, where patients have very regimented inclusion and exclusion criteria, like Miss Perfect and Mr. Perfect, and patients have, exclusion of different comorbidities. In the real world, there's all sorts of patients with all sorts of comorbidities. And so you can understand what happens once a treatment moves from a clinical trial to the real world. And registries can also be used to look at the natural history, because many clinical trials are short and don't include long-term data. It's a prospectively designed registry that's web-based, and we have quality assurance measures to ensure that the data we collect is accurate. There's a statistical back-end software for analysing the data, and it's utilised in routine clinical practice. So it's compatible with being able to run a busy clinic, but also collect your outcome data. We have around 87 users at 77 sites currently in Australia, New Zealand, Spain, Italy, France, Germany, and Switzerland, and collected over 30,000 visits from over 6,000 eyes of about 3,500 patients. And amongst that, 3,200 patients have been cross-linked. The data we collect include demographics, family history of keratoconus, any medical history, vision, corneal shape factors, and cross-linking treatment protocols, along with adverse events, and also patient-reported outcomes. And I'll talk a little bit more about this later. So we went and repeated our natural history study on data from the SAVE site registries. And what we found here is people that progressed, and that was a change of 1.5 doctors in their Kmax. Here are the, not sure what that color is, peach, versus the aqua is the stable keratoconics. And it was the younger keratoconics that were progressing, and the keratoconics also with steeper Kmax and K2. And so we concluded from the real world data with modern topography that a patient that was 21 years old was more likely to progress than someone that was 26. Again, the Kmax of greater than 55 meant you were more likely to progress. And both K2 and K-mean were found to be sensitive measures. And over 12 months, we found progression in patients. And so this is important. Here we, in Australia, we have public cross-linking as well as private, and some of those patients can spend a bit of time on waiting lists. So it's important to review the lists and make sure people have the cross-linking in a timely manner. We've just added an optometry module to the registry, so optometrists can also put data in, and they can refer their data to the ophthalmologist and vice versa. And this has enabled seamless patient care. The optometrists are collecting refraction data as well as information on contact lenses. Okay, so what you can say to Sally is that, look, you're young and you do have steep corneas, so it's likely it may get worse even within the year, but you won't lose your vision altogether. Now, because I can't be here in person, I've included some photos of me giving lectures, because they're the only photos I could find where I was actually sort of talking and it would suit the speech bubble. So then came Peggy, and she'd been told that her keratoconus had progressed and she wanted to know more about cross-linking. She wanted to know what the cross-linking would do for her keratoconus. Now, what I said to Peggy is, look, the cornea is a bit like a sandwich. It's got a number of layers and they're one on top of the other. And what happens in keratoconus is that those layers slip upon each other. And this means the cornea ends up with an irregular shape. The keratoconus can restore the shape. Now, with the SAVE site registry, we have been collecting outcomes data on cross-linking. The data has been accumulating at a rate of about 35% increase per annum, and clinicians contribute data to the registry because they get benchmarking reports where they can compare their practice to the data from all centres. And patients, when they come to the clinic, can see their patient journey graphed, looking at their vision and their K2, sorry, over time. Clinicians completing the registry in Australia also get CPD accreditation points. And we wanted to know whether using the registry would impede the flow of the clinics. And to have a look at this, we conducted a workflow study where we looked at time in motion in a hospital clinic and found that if you had a new patient that you're putting on the registry, there was actually no impact on total consultation time, time spent interacting with patients, or use of the patient records, and overall clinicians were quite satisfied. For a patient that is already on the registry, the time is less than traditional notes because you don't have to look back through files. All the information is displayed in the graph. The impact we found, it meant that it was minimal, so it could be easily integrated into care. We looked at the outcomes that we collected for patients that were still being followed up 5 years after their cross-linking. There was sort of similar-ish numbers of accelerated and long UV duration cross-linking. And over the 5 years, we found from 1 year to 5 years an increasing proportion of patients gaining 15 or more letters, an increasing proportion of patients with flatter, more than 2 diopters flattening of their Kmax, and a reduction in adverse events, such as that most of the events occurred early on. Vision, on average, improved by around 8 logMAR letters. There was initial thinning, and then the thickness of the cornea returned to normal, and Kmax did flatten slightly over time, but there was no significant difference in the mean for Kmax and K2. Now, as well as being able to tell the patient that their keratoconus will likely stabilize over time with the cross-linking, it's also important to let them know what the procedure involves. It's generally, particularly with epithelial off cross-linking, very painful. And patients often have a lot of questions about what will happen on the day and after. So we developed a brochure that can be downloaded from the web that informs the patients about the cross-linking procedure. And this was developed in collaboration with Dan Gore at Moorfields Eye Hospital. Patients may also want to know what might happen in terms of corneal grafting. Many patients with keratoconus often go to the internet and find out that corneal grafting is an option. And what we can now tell our patients is that due to cross-linking, there's a reduced frequency of penetrating grafts being performed, with rates halved over the last decade. But if the patient does need to have a corneal graft, the complication, success rate, and outcomes are similar, whether they've had cross-linking or not. So in summary, cross-linking has a lasting effect. I told Sally that vision and her corneal shape may improve over time, but they definitely stabilize. And if she did need a transplant, if she probably wouldn't need a transplant, sorry, but if she did need one, she could still have one. Now, what type of cross-linking should I have? This is a common question. There's a lot of information, again, on the internet about cross-linking and the different types. Broadly speaking, the 2 main types currently on offer are conventional cross-linking and accelerated cross-linking. In conventional cross-linking, this is also known as the standard or Dresden protocol, 30 minutes of UV is delivered at an average of 30 milliwatts per centimetre squared. The UVA is at 370 nanometers wavelength, and that's the same in accelerated. But in accelerated cross-linking, it's delivered at over 10 minutes at a higher wattage of 9 milliwatts per centimetre squared. But for both procedures, the cumulative energy dose is the same. Accelerated cross-linking is based on the Bunsen-Roscoe effect that says the chemical reactions will occur the same with the same amount of energy, and so there is an increase in energy and a reduction in time. Now, we use the SaveSite Keratoconus Registry to perform a large study to look at the difference between accelerated and standard cross-linking to understand what's happening in the real world. This included 725 eyes of 588 patients. In the 2 groups, the average age was around 26, and most of them there were more males than females. At inclusion, the age, gender, vision, Kmax, K2, and thick mean corneal thickness were similar between all the groups. And this study included 24 sites in Australia, New Zealand, and Italy. And what we found is that there was a mean improvement in vision in both groups, but no difference between the two. There was a decrease in mean Kmax in both groups, but no difference between the two. There was a decrease in mean K2 in both groups over the 12 months, but again, no difference between either conventional or accelerated cross-linking. The minimum corneal thickness initially reduced, more so in the conventional group, but then returned to similar levels by 12 months. Adverse events were similar, but there was more haze initially in the accelerated group than the conventional group early on, but by 1 year, the rates were about the same. Overall, there were similar rates of adverse events with the accelerated group, though, having more earlier on. Now, this was data from the data I've just presented was from our registry, but there's also interesting data coming out from lots of other centres, including your own, and I'm sure you're aware of this excellent study that highlighted that younger patients and those with higher pre-op Kmax needed to be monitored closely for progression, and that pre-op vision could also be used as well as topography for refraction and thickness as predictors of outcome. So what could we tell Peggy? Well, we could say, look, both cross-linking procedures are similarly effective. With both of them, you'll stabilize your keratoconus. You may also see some improvement in vision and your corneal shape. Overall, the adverse events, if they are to occur, will be low. But accelerated cross-linking may be recommended for its time and convenience. In the literature, other studies have looked at accelerated versus conventional cross-linking. The trend is towards showing that they are equal, though some studies have shown slightly worse outcomes. It's difficult to perform large randomized trials of these techniques, but I hope our real-world data contributes to being able to provide some answers to patients. But is cross-linking safe? So when we looked at our adverse events with the number of patients, having them recorded at 1 year and then at 5 years, we found clinically significant haze to be the most common. Now, this wasn't any haze. This was haze where the ophthalmologist thought that the haze that was present was contributing to reduced vision. And that's what we meant by clinically significant. And that happened in around 14% of patients, but most of it had resolved. Scarring occurred in 2.5%. Sterile infiltrate, stromal edema weren't common, but did occur. We saw microbial keratitis, some patients with persistent defect, recurrent erosions, and steroid responsive glaucoma. In terms of clinically significant haze, looking at our 12-month cohort data, out of 688 eyes, we had 161 cases from 95 eyes in 80 patients. And the mean age of these patients was around 22, 26% female, moderate baseline vision, with Kmax on the steeper side, and K2 a little bit steep, and pachymetry not overly thin. There was an equal proportion, or fairly similar proportion, of patients who'd had short duration cross-linking who had haze and those that didn't have haze. But overall, we found that clinically significant haze was more likely to occur if the patients were younger and if they had steeper keratometry. This information might be useful, as you could use it to taper your post-op treatment and also counsel patients that might be at increased risk of haze. For these patients, you might need to monitor them more closely. What about keratitis? This is a terrible complication when it does occur. We looked back over 7 years and we found 11 eyes from 10 patients that had been treated at our institution, the Sydney Eye Hospital, with keratitis following cross-linking. The mean age of the patients was 29 years, but they range from 16 years to 48 years. And most of them presented around 4 days after cross-linking, but there were some presenting late. The initial vision at presentation was poor, and this was the vision when they had the keratitis. For some patients, we didn't have a pre-morbid vision, and the final vision, there was some improvement. But overall, the vision was still low. The culture positivity rate was quite high at 92%, whereas for microbial keratitis in general, it's usually about 60 to 70%. And we found 13 isolates, coagulase negative staph in 50% and Staph aureus in 25%. The patients took around 30 days to heal, but some took longer. So with post-cross-linking microbial keratitis, it seems to be that we had mainly gram-positive bacteria. Some of our patients were atopic, and atopes have a high rate of staph carriage on their eyelids, and this may explain why they got gram-positive keratitis following corneal cross-linking. Others have reported acanthamoeba and fungal keratitis post-cross-linking. Delayed epithelialization was a feature in our study, and the patients had moderate to poor outcomes, with many left with central corneal scarring. We calculated the incidence of patients that had developed developed infection with the cross-linking performed at our institution at 2.4%, which is similar to some other series. This is a patient I treated recently who'd had cross-linking. He had atopic keratoconjunctivitis. We weren't too sure on his compliance, but he had cross-linking, and post-operatively he was put on prednisolone fort and ofloxacin. He then came in with the cornea looking slightly hazy. There was still a large defect, and at this stage a keratitis was diagnosed and a swab taken which grew staph. The swab result wasn't available for 2 days, and so he was initially again continued on ofloxacin. But this actually didn't cover the gram-positive organism. When I saw him, his cornea looked like this, and the keratitis had progressed. Not only was Staph aureus cultured, but further sampling grew Staph capitis and Staph epidermidis. It was sensitive to chloramphenicol, as well as one of them was sensitive to kefalofen. So it's important to think about patients having cross-linking with atopic eye disease and manage any lid disease before they have corneal cross-linking. If the patients develop keratitis after the cross-linking, consider it might be gram-positive and make sure you have sufficient cover. Post-operatively, your prophylactic antibiotic regime should also include gram-positive cover. Now, this was a case series of particularly bad complication that we saw following corneal cross-linking performed at another center, where the riboflavin was compounded. And unfortunately, it was compounded with dextran T500. It was meant to be compounded with dextran T500, but it's actually substitution, and dextran sulfate was put in. And this resulted in severe corneal scarring and corneal melting. It was almost like the patients had had a chemical burn. Unfortunately, there were 6 patients treated on the 6 eyes treated on the one list, and all patients developed the same complication. The patients required corneal transplantation, but the damage was severe and went to the peripheral cornea, causing scarring and vascularization, which compromised the results of subsequent corneal transplantation. You can see on the corneal graft donor specimen here that there is a lot of inflammation and destruction of the corneal stroma. So in regards to Peggy wanting to know if her cross-linking is safe, what we can tell Peggy is, look, your corneas may get cloudy, but this usually resolves. Loss of vision is still a risk, but it's not common. But take care post-op with your hygiene. Don then wanted to know, look, do I need surgery? And who really needs surgery if you have keratoconus? Well, historically, about 1 in 5 people required surgery, and this was over a 5 to 25 year period and reported by Steve Tuff from Moorfields in 1994. And the patients having corneal grafting all had advanced keratoconus, and they all had penetrating keratoplasties. But times have changed. There's now improved contact lens fitting. Scleral lenses are available to more. There's limbal lenses, there's piggyback lenses, and there's improved skills of optometrists in fitting the contact lenses. There's technology such as intracorneal ring segments, deep anterior lamellar keratoplasty, topography guided PRK, with or without cross-linking, mostly with, phakic IOLs, keratotomies, femtosecond laser assisted grafts, and pinhole IOLs that aim to reduce the aberrations. So when might Don need to consider surgery? Well, the typical circumstances under which patients with keratoconus have surgery include when there's poor contact lens tolerance despite adequate treatment of ocular surface disease. So patients with keratoconus may be more inclined to have atopic eye disease, and this can sometimes be difficult to manage and preclude contact lens wear. Some patients may have trouble handling contact lenses. They're unable to get them in. Sometimes it's impossible to get a stable contact lens fit, particularly if the cone is very steep. In these circumstances, scleral lenses might be considered, but they can be harder to wear and also fit. Despite contact lenses, vision might be poor. This might be a patient with apical scarring. In early hydrops, there can be acute neovascularization. In some cases, they're penetrating or keratoplasty may be warranted. This is one of my earlier papers published in 2004, where we looked at deep lamellar keratoplasty versus penetrating keratoplasty in keratoconus. There's been many other papers published on the subject since. This was one of the first to look at these two groups and compare them. And we found that dark really did offer a good choice to patients with keratoconus. Vision was very similar, and there was a reduced risk of rejection and late endothelial failure. This paper also from your institution I came across, which explains more about when you might do cross-linking alone, cross-linking with rings, and cross-linking with topography-guided PRK. And the conclusion of the paper, which you might already be aware of, but I thought was worthwhile to include in the talk, was that cross-linking alone might be best for keratoconic patients who meet the inclusion criteria. If you're putting rings with the cross-linking, it might be more effective for eyes with irregular astigmatism and worse corrected distance vision. And cross-linking with topography-guided PRK could be good for eyes requiring improvements in irregular astigmatism, but still having good distance vision. But when we're thinking about what outcomes we want from our patients, it's important to remember that it's not just vision. Clinicians often use vision as, or topography as the ways of judging whether the patient is having a benefit from the treatment or improving. So patient-reported outcome measures actually allow us to reduce the disparity between the clinicians and the patients to make sure we really are asking their questions and answering their concerns. When we looked at vision-related quality of life in keratoconus, we found that overall day-to-day functioning was determined mainly by the patient's better eye. And so this is often we look at the better eye and we assume that the patient will function based on the vision in that eye. But the vision in the worst eye can actually influence the quality of life and well-being for the patient. So it's important to keep this in mind when treating patients. This study, like others, used the IVI, the Impairment of Vision Impact Questionnaire. But this questionnaire is mainly used for age-related macular degeneration. It's based around low vision. So we wanted to find actually the best way of measuring quality of life in patients with keratoconus. There's a questionnaire that's been developed called the CORQ, or the Keratoconus Outcomes Research Questionnaire. And when we performed a systematic review, we found that it actually had the best qualities for assessing the benefit of treatments to patients with keratoconus. And we've integrated it into the SaveSite registries. It's valid and it's psychometrically sound and based on rationalysis, which is a more modern psychometric method than other quality of life questionnaires that have been used for keratoconus. And it includes questions based on activity limitation and on the patient's symptoms. Using questionnaires that just assess vision for patients with keratoconus don't take into account the issues patients can have with their vision due to glare and contact lens wear, and this questionnaire does. How we use it in the registry is electronic. Patients are able to fill out the questionnaire on an iPad in the waiting room or via a link that we send to their phone or device. And then the information from the pro ends up in the registry and the clinician can view it straight away. The ability and the symptoms are given a score, and this can be used to track the outcomes of the patient along with their vision and their keratometry findings in real time whenever they come to the clinic. So, Don, surgery could be needed if you cannot meet your visual needs with glasses or contact lenses. There's a variety of treatments now available, and the treatments really need to be tailored to the specific needs of the patient and their condition in terms of their vision and their ability to wear contact lenses or not, and the degree of irregular astigmatism. But what else might happen to my eyes? Don was wondering. And one of the problems that keratoconics can have, which I've spoken briefly about before, was predicting is problems with their contact lens fit. And this is because many can suffer with atopic eye disease. It can be seasonal or perennial, atopic, but rarely vernal. And patients then end up with a contact lens-associated papillary conjunctivitis, which you can see here outlined by the fluorescein staining. To manage this in contact lens wearers, you start with mast cell stabilizers, antihistamines. Some patients may need steroids. And remember, if you do use steroids, to check for the discs as well as the pressure. Cyclosporin I've found to be very useful and can be formulated up to 2%. It can start to sting once you get towards 2%, so 1% sometimes can be quite helpful. And what you can do with cyclosporin topically is use it to reduce the need of steroids. And this is particularly helpful in patients that are young. To prevent and manage contact lens intolerance in keratoconics, you can advise them to make sure that they keep their contact lenses up to date, avoid using contact lenses that are scratched, ensure they have good hygiene by cleaning correctly, use any medical therapy for their allergy, consider using PMMA lenses rather than soft or toric lenses if they're suffering with allergy. And then you can ask the optometrist to modify the edge or the fit, or the lift or the fit, particularly with sclerals. Piggyback contact lenses can be considered. This is where you have a soft contact lens with the hard contact lens on the top, and this can improve comfort greatly. Some patients sometimes end up with little localized scars on their cornea, and this can interfere with contact lens fit, and so they can just be gently removed to improve the fit. If your patient develops hydrops, when it's very bullous, give some prophylactic antibiotics. I've seen some quite severe microbial keratitis in patients with hydrops. And I think this is because the bacteria can spread very freely in the edematous cornea because the stroma is loosely compacted. If the hydrops is severe and peripheral, then you can give topical steroids to prevent vascularization. Often you can defer surgery and wait for the hydrops to resolve. And this is because in some patients, the vision and the lens fit may actually be improved or unchanged. This is because hydrops can cause scarring and the scarring can cause flattening. If there's early and aggressive neovascularization, you may want to consider surgery. Otherwise, the vascularization can remain and put at risk any future corneal transplants. Recent case reports and series have looked at the use of intracameral air, SF6, C3F8. The idea is that you inject it into the anterior chamber and it tamponades Descemet's membrane in the break to lead to a faster resolution of the hydrops. In these limited case series or reports, it has led to a faster resolution of the hydrops, but there are concerns that it may cause cataract, that there may be endothelial loss associated with it. There's a risk of pupil block, and patients do need to comply with posturing. And this can be an issue, particularly if you put a long-acting gas into the anterior chamber. So what else can happen?
I found this on the web.
Sorry, that was Siri. So what else can happen? Well, with treatment, you know, what else can happen if you have keratoconus is that your contact lenses may cause an issue. But generally with treatment, we can get you back into your contact lenses. And if your corneal swells, it might take time to settle, but your vision might return or in some cases improve. Now, lastly, with the registry, we've been tracking what's happened with COVID. And when COVID first hit Australia and there was a lockdown, we noticed a steep decline in the number of visits and cross-linking procedures being performed. We have sites across the globe, and those countries also experienced quite sudden and precipitous decreases in patient attendances and cross-linking procedures. It's important to remember at times when there's other health crises that patients with keratoconus still need their treatment and need monitoring in order to pick up whether they are progressing, because cross-linking can stop progression and there's treatments that can improve vision. So today, our real-world data across multiple countries supports cross-linking as an effective treatment for progressive keratoconus. There's positive outcomes, including improved vision, stable Kmax, K2, corneal thickness that are sustained at 5 years. And using the real-world data, we can watch the impacts of COVID and make sure our patients receive care. There are a few late adverse events with cross-linking, and now we have a range of treatment options available for patients with keratoconus. But for tomorrow, we still need innovation. As we need new therapies. We need to continue to evaluate and improve our practice. We need to understand what the benefits and natural history are in patients' terms and the patient's benefit and the patient benefit of any treatments. We need to be able to provide answers to patients that are real solutions to their issues in order to be able to continue to transform their lives into the future. I'd just like to close by acknowledging the team that's behind the Save Site registries. We have postdocs, students, statisticians, project managers, software engineers that all work to make sure we can collect the outcomes data in day-to-day practice and feed it back to the participating clinicians so they can learn from their patient data. I'd also like to thank some of my collaborators who have assisted with the work that has gone into the presentation and the steering committee and collaborators as part of the registry. Thank you.
That was great. Thank you so much, Stephanie. That was an amazing overview of keratoconus and just hearing about your disease registry. I really think, having that big data available is really going to make a huge difference in terms of how we are able to treat patients and guide them in the future. So thank you for showing us that and sharing your research with us. It's amazing. One of the questions I have is, for the comprehensive ophthalmologist, something that comes up time and time again is, do they, when they see a patient with keratoconus, let's say typical young patient, do they wait to make the referral to a cornea specialist? What are your thoughts on that? Do they wait for progression? I can tell you sort of what our experience is here and what I do and what my feeling is, but I'd love to hear your thoughts on that. The second question I have, last night we had a cornea journal club actually, and one of the papers we reviewed, we were very lucky to have Damien Gatnell on the Zoom call with us, and he's one of the authors of eye rubbing and the role of sleeping with keratoconus. And, it's so interesting to hear his thoughts on risk factors and how he manages keratoconus. In fact, he doesn't even typically offer cross-linking to patients. I don't know if that's something that we feel comfortable doing here, but he really truly feels very strongly in the role of eye rubbing. And if you can manage patients' eye rubbing and how they sleep, you can actually make a huge difference in terms of progression. So there's two questions that I have, and then we can open it up to the group. And I'd love to hear other people's comments as well.
Yeah, so I think for the comprehensive ophthalmologist, I think the information on natural history is important. So for young patients and steep patients, I would refer them straight away to a corneal specialist because they can progress very quickly. So, anyone, a natural history data said less than 17, but generally sort of less than, 20, but particularly if they're less than 15, I think that's quite urgent referral. If they're, 40 and they've picked up to have keratoconus and been wearing funny glasses and not really eye rubbing, then I think, and the comprehensive ophthalmologist has access to topography, then they could sort of follow them up again and see if they're stable or not. So I think it's sort of risk stratification and because you can have this progression in the young patients happen really very quickly. And sometimes also if they're progressing, they might need management of their atopic eye disease. And you might need to prescribe cyclosporin or sometimes even work with the pediatric immunologist to achieve the best outcomes. Now, the second, so it's late here, the second question was about the eye rubbing. Yes, as part of the registry, we are collecting data on eye rubbing and allergy. My experience in the clinic is that I do see patients that progress that are not eye rubbing, and they can be young. There's patients also, it's a funny disease. I have one patient, the son of an ophthalmologist, and he was 6'12" in one eye with keratoconus, and I first saw him when he was about 13, and he was progressing in that eye, so I cross-linked it. The other eyes had 6/6 vision, grade 1 keratoconus, and he's now 21. And he hasn't progressed in that eye. So, I think there is some evidence that cross-linking, that eye rubbing has an effect, and people may progress. But I personally, in clinic, I haven't seen that correlate directly in all cases. But I think it's a consideration, probably something that is worth counseling patients on, to tell them not to rub their eyes.
Yeah, no, I agree. I think that, he talks more about the asymmetrical keratoconus. And, we know a lot about the natural history of the disease, and that patients, in their 20s and 30s will definitely progress. I think here in Toronto, we do also recommend cross-linking pretty quickly. I think it's still a fairly safe procedure. I see the numbers that are presented with regards to haze, and that definitely mirrors our own data. So we've looked at that as well, and the risk is about 10%. In our experience, we haven't found that it's necessarily just the steeper Ks in the younger patients. We have a very large immigrant population here in Toronto.
Yeah.
And so we see a lot of East Asians, a lot of African Americans, and definitely we feel that risk group, that demographic is at a high risk. And our own experience has been that sometimes, these are young patients, and although it is a very safe procedure, the issue of haze is something that does need to be counseled to patients. It does typically disappear, over time, but it can be a long time. And so sometimes if you take these patients that are actually 20/20 young and cross-link them, and they come back with grade 3 Hannah Hayes, you have to hold their hands for a while, and it can be quite discerning for them, but usually it disappears. Hull, I know you're on the line, Hull Chu, who I think knows Stephanie very well. Maybe you can talk a little bit about your experience with haze. I know you've had a few patients that have, that you've had to manage as well.
Yes, I have a few patients. First of all, I want to say thank you to Stephanie for coming and giving a great presentation. That was an amazing presentation. I'm very sorry we couldn't have you over this year for Walter Wright. A little thing came up. I'm sure Alan talks about it all the time too, but little thing came up in the world. But we look forward to having you join us in the next couple of years when we have our Walter Wright cornea specialty again. And I hope you're well. Thanks again. We've had a few haze issues here. I don't know, I find it generally in people who are have more pigmentation, people who have more kind of an allergic reaction, atopics, as you mentioned. But in general, I try to treat them more aggressively with steroids and hygiene, as you noted. And I try to reduce the amount of alcohol that I place on the eye when I do the keratectomy. I find sometimes if you do more than 10 seconds, I find that people may get more haze that way. I was interested to know what your thoughts were on that.
Yeah, look, that's interesting. Definitely, I definitely treat them with more steroids. And that that can help settle it down. The alcohol is an interesting question. We haven't looked at that, but that's something we do have registry data on. So I'll go and have a look at that and report back.
Yeah, I find sometimes we put the alcohol in the well, and sometimes these people are a little bit more fidgety and they move, and it ends up going all over the place. And maybe that's one of the issues. So I try to minimize that best I can. So, anyways, thanks very much, and it's so great to see you. I wish you were here.
Thanks.
So we have a few audience questions. Tanya, can you maybe read them out, and Professor Watson can answer this for us?
Great. Thank you so much for the amazing talk today. We've got some interest from the audience, just a few to clarify and a few bigger questions. Dr. Mednick, one of our cornea specialists, wanted to know, is the improved vision seen in the cross-linking studies that you had presented attributed more to the CXL, or was there any papers that were included that had undergone any PRK treatment at all?
No, just the CXL.
Okay. Yeah. And another question from, I think, Dr. Scheiman, who wanted to ask whether the cross-linking without corneal epithelial removal decreased the incidence of post-treatment infectious keratitis, and if the case series that you presented has influenced your thinking around that treatment in any way.
Yeah, look, the ideal way to do cross-linking would be without the having to take the epithelium off. The data on sort of epithelial on cross-linking is still emerging. And so we're sort of waiting for the evidence to show that it does sort of work in all cases, as well as epithelial off. And I think it's also dependent on the type of riboflavin you're using, which different people have access to different types. But yes, definitely, even disrupting the epithelium is a risk for keratitis.
And another great question from Dr. Zaslavsky, who also says, thank you for a great talk. He wanted to know, they wanted to know, what were the biggest challenges in creating the Safe Site registry and your biggest challenges in maintaining it?
So, I mean, in creating it, there was already the sort of the retinal registry. And so we had a lot of the programming work already done. It's a modular system. And so it was easy to sort of add on another module, but there's a lot of privacy regulation that goes around it, a lot of policy, because clinicians are putting patient data in, which is they can retrieve their own data and they can retrieve their patients, but nobody else in the registry system can know who their patients are. So around sort of anonymization is another issue. And then it's really clinician uptake. And that is sort of educating clinicians and providing CPD accreditation. And then once they've started to use the system and they see that they can get benchmark reports and that they can show their patient their sort of treatment journey, if you like, then they tend to stay using it. Some people also use it for research because they like being involved in the papers and seeing the outcomes. So it's sort of a multifaceted approach to engagement, but engagement is a piece of work as well.
I think I see a hand up. Alan, you have a question?
Yeah, actually two. First, could you comment on your use of collagen cross-linking for therapeutic purposes other than keratoconus? For example, treating difficult to treat corneal ulcers, fungal or acanthamoeba. And the other one was, we had a patient come in with a hydrops last week, and there's some recent work showing that pre-decimate sutures can cause resolution of that. Have you had any experience with that?
Not with the hydrops, no. I mean, I've read that if you've had cross-linking, you can still get hydrops, and that episodes are meant to be much shorter and limited, and you can even get a hydrops straight after cross-linking. But I haven't had any experience with pre-decimate sutures.
There's a paper just published on it. Yeah.
Yeah, I'll have to go
it's
and
new.
go and read it tomorrow morning.
Kind of goes against a lot of what we think, because you're going to cause some scarring regardless of how good your suturing technique is. Reporting good results.
It sounds technically tricky, and I mean, it's often very hard to see where the desmase, you know, if you've got quite established hydrops, how to see where the actual desmase is and what you'd be stitching. I imagine technically it would be difficult. Maybe you could use the intraoperative OCT or something, but I mean, suturing have been around for 2,000 years, but it's actually quite a low technology technique, even though we use it a lot and it's effective for things, but I imagine it'd be quite tricky.
I agree. And plus the fact is, in some of these real acute hydrops, it's hard to see where the tear and desmase membrane is. Yeah. What about treating infections? Have you had much experience using collagen cross-linking for recalcitrant infectious keratitis?
Yeah, look, we don't tend to do it here. The problem with that scenario is if it is acanthamoeba then and fungus, then it doesn't penetrate deep enough. A lot of the series that have been reported on it have sort of had cases that were culture negative or had other treatments or were treated quite late or had, so the evidence base is mixed on it. So we haven't actually taken it up and done it. It's also sometimes not very practical. We tend to sort of do corneal biopsies, try to, get a better, figure out what organism it is and then target treatment to that. So we haven't actually done a lot of that.
Thank you so much, Stephanie. I think that based on the time and the fact that it's 11:30, I think, in Australia, and we want to give you a break before you get into the resident lectures. So thanks so much for that. I think we should wrap it up. I'd like to just turn it over to Dr. Lloyd, who's our program director. John, if you want to say a few words. You're on mute.
There we go. I am. Just my button wasn't working for some reason. So thank you very, very much. So I believe it's getting well into the late night hours there. And so we just want to thank you again, Dr. Watson, for this phenomenal talk, seeing what's going on. And I'm curious how it looks so light out in your background, but I assume that's a photo behind you there, and you're really also in your pajamas, I guess. So thank you very much for speaking to our residents, and they have no excuse for sleeping if you're not asleep, as you tell them all sorts of information. So thank you very, very much again. Very informative. And I'm just curious, do you think the high incidence of keratoconus in the Middle East extends throughout the entire region? And do you think we're missing even more keratoconus in some of the other areas? That's my final question before we sign off.
Yeah,
Is it,
look,
in fact, do you
there's
think our incidence in North America is higher than 1 in 2,000, given that yours is 1 in less than 1 in 100?
There is some evidence that, that there's a latitude gradient effect with keratoconus, that it's higher in areas where there's more UV. We've actually been doing some lab work with models looking at the effect of UV on the cornea at certain doses that are enough to produce sort of skin damage. And if you do it to a mouse, they actually end up with keratoconus. So, you know, there could be some advantages of being there in winter and missing out on that sun. Yeah, but I think there's a lot we don't know.
Fantastic. All right, the residents are very much looking forward to your teaching, and for the rest of us, we will see you next week.
Lovely.
Thank you.
Thank you.
Thank you so much. Take care. Have a great